Hi, everybody. It's Karen Anderson here with Aortic Hope for a very special Q&A. At least it's very special to me. But before we get into this, I want to remind all of you to please click like, please click follow, because this way you'll be notified every time we have a new video for you to watch, and also click subscribe. I am super excited because we have my doctor, Dr. Ghoreishi with Johns Hopkins University. So I'm going to take a second and let you introduce yourself to everybody before we get started.
Thank you very much, Karen. I'm Dr. Ghoreishi. I'm the director of the Aortic Center at Johns Hopkins Medical System in Baltimore. And I'm very excited to join you with this session and talk about some of the aspect of aorta, aortic valve disease, aorta. And so Karen, first I wanted to thank you for really putting this all effort for patients with this disease. And it is very valuable for me how much you and your team and you're putting together a really huge amount of effort to make sure these patients are not left behind, and the whole community are thinking about them and make sure they get back to their work and whatever they've been doing before, and they are fine. Just keep pushing and stay with the hope, and all good. So I'm very excited for today.
So am I. Well, I'm excited because everybody knows in this community that I'm very much an open book. I find that if you're able to and you're comfortable being open and honest and sharing your stories, a lot of people feel very validated when they hear things you say. They say, oh my gosh, she's just talking about something I've never said out loud, or this happened to her too, etc. And I just had surgery with you, October 29th of 2025. And so today's focus, which I bet a lot of people were thinking it would be about aortic dissection because it's everywhere in the news, I decided to change it up a bit and again, make it about me. And I want to talk a little bit about our relationship and as patient and physician and how it all got started, because one of the things I developed while I was waiting for my surgery for the week, I developed the patient surgical plan while I was in there, which is a new initiative. It's a tool to teach people how to ace their healthcare journey by advocating, communicating, and educating. And in this patient surgical plan, I really didn't realize how much control and say-so a patient actually has over their care. Things like, I'm going to have a chest tube taken out. I'd like a little bit of Dilaudid, please, while you do that. Or, I want only so many visitors to come in, or I want to make sure I have a hospital bed waiting for me at home. All of these things that nobody realizes if they have a dissection, because it's just such an emergency, you're just kind of going with the flow. So I came to you because while my echo was showing mild to moderate regurgitation in my aortic valve, and we're going to talk about what that actually means in a minute, it was because I was symptomatic. We had a discussion and we decided it was time. So before we get into what that all means, let's talk a little bit about aortic valve disease, and if you can explain what that actually encompasses, because I know it's primarily like three things.
Right. So, heart pumps the blood to the aorta, and there's a valve between the heart and this big tube aorta. It's called aortic valve. It can be bicuspid, that means it has two parts, or it could be tricuspid. It has three parts, that opening and closing. And in patients with aortic dissection, that they had a history of aortic dissection, this aortic valve can be involved during aortic root involvement, or no, the dissection wasn't involved in this. And so the aortic valve over time, when the tissue around it, the aortic root, starts to dilate, the aortic valve can become leaky. That means these two or three parts in patients, they don't see each other in the middle anymore, and it starts leaking. Usually, we just observe patients that they have mild or even moderate degree of leaky valve. But if it amount of this regurgitation or leaky valve becomes severe, then it's about the time to start talking about fixing this leaky valve. It's very hard to time to identify between moderate and severe. Yes, mild, we can identify it on the echo to see if it's mild. That means some regurgitation happens, some blood comes back to the heart. But when it's between moderate or more, sometimes we are talking about 1 or 2 pixels on the echocardiography that we see as a modality for leaky valve. And so we would rely on other modalities, including MRI, to really tell us, okay, is this amount of regurgitation significant or not? Also, we will pay attention to the symptoms. If the patient has symptoms, that's other reason that we think that this regurgitation is more than mild. What amount this leaky valve, moderate or severe, would affect on the heart? Over time, the heart starts to distend, dilate from a kind of a golf ball size, starts to become like an apple size heart, and then grapefruit size. And then, unfortunately, I've seen patients, they come with like a, watermelon size. At that time, it's too late. The heart has been so distended, the muscles become very thin. Why? Because it got distended. Now the muscles of the heart is now very thin, and at that time it's too late to be able to remodel this heart back to smaller size. So it's very important that if the patient has severe leaky valve, that's most of the patients with a history of aortic aneurysm or dissection get. Aortic stenosis is another disease of the aortic valve, but in patients with aortic aneurysm and dissection, aortic valve regurgitation, we see that most often.
Okay.
Why? Because the tissue around it starts to dilate. The aneurysm around the aortic valve starts to dilate. And so regurgitation, we see this in patients with a history of aortic dissection or history of aortic aneurysm, that their ascending aorta has been replaced and the aortic valve at that time wasn't leaky, or the aortic root wasn't dilated or aneurysmal. So if we follow patients that they had a history of dissection or history of ascending aortic aneurysm repair, some of these patients come back because of the dilation of the aortic root. Now they have leaky valve. So unless in their primary operation, when they had a dissection, they had aortic root replacement or a valve sparing aortic root repair, that means they spared the valve during their initial operation. So bottom line is, we follow patients until we make sure that this aortic valve is stable. If it becomes moderate or more, and then we have to do some testing, including MRI, to see how much it's leaking. And it really gives us a lot of information about dilation of the left ventricle, about the function of the left ventricle, ejection fraction, and about, okay, regurgitation fraction, how much actually it is leaking. 40%. On the MRI, if it's regurgitation fraction more than 40%, that is significant. And it really gives us very good imaging. Again, I want to emphasize, I see a lot of patients outside in the community that on the echo, they have some short of breath or difficulty catching their breath after 1 hour walking, and they get MRI and they get echo, and on the echo it says moderate aortic regurgitation. And so that's it. No more modality anymore. No more assessment. They feel like, okay, this short of breath, it could be from other reasons. It's very hard to identify between moderate or more severe leaky valve on the echo. And we are really pushing to rely on other modalities, including MRI, to tell us, okay, if this is moderate or more. Why? Because we really don't want to get to the patient late. If the ejection, if the heart function is dropping, that means, okay, this heart is under stress, it's dilating, and we do not want to get to this patient late. So when we got MRI and it tells us regurgitation fraction is high and LV is getting distended and heart function is declining, then at this point, fixing this valve is indicated based on the American Heart Association guidelines and Society of Thoracic Surgery guidelines. The options to fix this valve depends on the comorbidities, conditions patients they have. We assess patients, and case by case is different. If the patient is young and
define young.
So if the patients we feel like really it's hard to put a number on this.
Okay.
All right, it really depends on a lot of factors, including the chest anatomy and if they had a history of dissection, if it's very frozen chest, if we feel like, okay, this graft and everything around, if the patient had a history of dissection, all of this are very close to the sternum or adhesions, and a lot of factors we look. Our plan is to make sure this operation, if it would be the last operation patients get. And so sometimes if we go and say, okay, we go to preserve the valve again and resect the tissue, aneurysm tissue around it, and put a graft into the aortic root and preserve the patient's own valve during this. Why? Because in aortic regurgitation, in root aneurysm, it's a stretch of these leaflets. If we resect the aneurysm, put them inside the graft, it's called valve-sparing aortic root repair, and bring this together, then we fix that leaky valve. But again, we want to make sure this is a durable operation, lasts for 20 years, more than that. If we look at the valve and we feel like, okay, they have some holes in it, it's very thinned out. If we even put this back together and these holes exist into this valve will last for 1 or 2 years, or maybe 3, 4, 5 years, and then they are back in the operative room with a leaky valve. Why? Because these leaflets were very thinned out because of the stretch or holes in it. So it really requires a lot of assessment to see how this valve, is it healthy to work with it and put it back together, or no, it's not healthy, it's not going to be durable for many years, and it's better at that time to replace the valve. The other option is transcatheter valve, which is TAVR these days. And if the patient, we have different type of valve, transcatheter valves. The valves been introduced, these transcatheter valves, per se, just for severe aortic stenosis. It hasn't been designed for severe leaky valve. Before, we used to do off-label use of the transcatheter valve that been used for severe aortic stenosis, put them in patients that we feel like they were very high risk for another operation, and put them in. Why? Because we think that valve would hold it inside the patients that had a graft before. But now there are new valves for per se just severe leaky valve. It's just one of them just got FDA approved, that we have it here at Johns Hopkins. But again, these transcatheter valves are for patients that we feel like they are high risk for operation. and going back inside the chest, it's going to be too morbid for them and high mortality. Why is that? First of all, these valves, the durability of these valves, we still don't know. Right now, the transcatheter valves that are for severe aortic stenosis, the durability of them is 10 years. All right. After 10 years, we have to do something else again. So we feel like if the first operation would be open and replace the valve, then 10 years, 8 years, 10 years, 15 years down the road, they can get a transcatheter valve across this old valve that are placed.
How many times can you do transcatheter?
So it depends. If the first one is the first valve that was placed was big enough, and that's what is very important. Operation, when we go in, we put a big size valve, 25, 27, 29. Stay away from putting 21 or 23. These are 5 sizes that we have in general.
Okay.
21, 19 is extremely small. I don't think anybody does it. 21, 23 are on the small size valve. The valve that we have, like in cardiac surgery, we personally believe should be implanted, should be either 25, 27, 29. Why? Because these are big valves, and down the road we can put at least we don't know yet, but definitely one, maybe even second. So the bigger, better. And so that if the valve is not preservable, if you feel like the valve itself has holes in it, the leaflets are thin, and it's not preservable valve, then we replace the valve. The options are again a tissue or a mechanical valve. We all know about blood thinner with a mechanical valve. If they have history of bleeding, a problem with bleeding, well, mechanical is not a choice. Then it comes with a tissue valve. And again, big size valve gets implanted 10 years, 12 years, 15 years, whenever it's time. I've seen patients I just saw a patient yesterday, had a aortic valve replacement 23 years ago. Amazing. And the valve's still working very well. So it's still, we don't know why in some patients the aortic valve becomes wears off fast. In some patients works for a very long time. Still research going on around it. So if the valve gets replaced, our goal is to put a big size valve, so down the road they get either another operation to replace them, to stage it for the TAVR, or no, get a TAVR again after that. So that's about the timing of the operation. That's about the type of the procedure for the valve. The Ross operation that time to time we use for patients with a severe with a leaky valve, aortic insufficiency. Still, we do that for patients that they are young, 20, 30, 40-year-old, no history of dissection, no history of hypertension, and no hostile chest, no other aortic connective tissue disorder, or Turner syndrome. These are some of the disease that we don't do Ross. In Ross, we use the pulmonary valve and put it in the aortic position. But again, it's the Ross operation is mostly for young patients with severe aortic stenosis, and that's the best option for them, and it lasts for a very long time, and without risk of infective endocarditis or using blood thinner. So Karen, in your case, you had moderate leaky valve, you had symptoms, you had a history of dissection, and which ascending hemi-arch, as 10 years, 8 years ago was done for you, and so your aortic root started to stretch a little bit, four to like 4.4, 4.5, and then this valve had on the echo, it showed moderate leaky valve. So, but you had symptoms.
Right. I think my ejection fraction had decreased and my
Right.
heart size had opened. And when I started getting symptoms, you don't even, I think, realize you're symptomatic until you take an Uber to go 2 blocks downhill. And you think, wait, this must be really bad because I can't even walk downhill. And I started having some fluid retention. And so I don't want to even have a needle, but I knew something had drastically changed and I needed to have that, reevaluated and discussed.
Right. And then MRI told us, okay, this is more than moderate. All right.
Mhm.
Don't rely on just the echo.
Yeah.
Again, I want to emphasize this. It is important for community, for everyone. If you have a short of breath and especially patients with aortic aneurysm, and then echo says moderate, people in cardiology's community, PCP, everything, well, this is moderate, nothing to do. It is very hard to identify on the echo moderate or severe. I'm talking about one or two small pixel yellow color that comes on the echo. That's that. So MRI told us, no, this is ejection fraction, regurgitation fraction of is 47, 48%. Above 40%, that is severe. And LV is getting distended, and that told us, okay, it's time to go after this, and so we came to the conclusion that I think if the valve is not preservable in your case, and which was very thin, and we decided to go with a tissue valve, and I think a big size valve gets implanted so that stage the patient for down the road, 10, 15 years, whatever the situation is. Again, I have patients that they stayed very healthy, very good. I can say like you, and active, and so even when they down the road they need operation, we close them very, good, that protected, so that re-entry, even as a third time, wouldn't be a hassle, wouldn't be a problem. Go take that old valve out and okay, put another one. But no, if the patient is really mentally not ready or comorbidity is added because they aged, then transcatheter valve comes in. In aortic surgery, 2 times, 3 times, 4 times redo sternotomy happens. I think this week so far I've done like 2 or 3 times redo sternotomy. It's not common. We do this all in aortic community, and why is that? Because their first operation was just ascending hemiarch. Their arch got distended, now need total arch. Now the root got distended, now they need root replacement. In connective tissue disorder, I get a lot of patients that, they're now coronary bottoms and root are now distended, now arch is distended. So, and we time to time try not to tackle a lot of things at the same time.
Yeah.
Depends on the patient's condition.
Right.
And then one last thing. These days, because of the new technologies, new devices, new stents that now or we have now, if the patient comes with a dissection, we also are more aggressive. That means we don't stay on just ascending hemiarch. We go with the ascending total arch. Why? Because the technology and the stents, that devices that now in our hands, allow us to safely, with a low risk of stroke and mortality, take care of a little bit more bigger part of the disease aorta, including arch, ascending, a little bit of the descending. That means frozen elephant, stenting to that. And yes, if they come and root is 4.85 centimeter at the time of the dissection, we replace the root as well. But in community now with a dissection, we are more aggressive toward the arch. Why? Because arch gets distended in most of the patients with dissection. and then leave the root alone, unless the root at the time of their dissection was already 5 centimeters or big. But
Right.
arch, we rather be more aggressive toward the arch, fix that, and then leave the root alone and give it time. So dealing with it 2 times, 3 times, 4 times is hustle for patients, but it is safe these days with all of the devices, technologies, and that we have in our hands. So again, case by case is really different. What we're gonna do in 10 years, 15 years with a aortic valve, tissue aortic valve that has failed. Are we gonna go with a transcatheter valve? Or no, we will go and replace it and then give it another 10 years for a transcatheter valve.
Well, I'm chuckling because I remember telling you I'm never having my chest cut open ever, ever, ever again. So I hope you did all that you need to do. You know, that was a week after surgery. I probably was saying that for the first few months, but you know, when I hear what you're saying and I take my emotion out of it, I will always say that abdominal surgery is worse than open
Yeah.
heart surgery.
Yeah.
And so, given the fact that if you say, Karen, I got to go back in because I know that I think my arch might be growing and I have an aneurysm on the descending. If you said to me, we got to do this, I got to do this again. And the way that you just explained it, well, I'm not going to sit there and say no. I'm going to say yes, because if the opportunity for me to have a longer, same quality of life is higher than if I don't do anything, well, then you just deal with the inconvenience for 8 weeks and you just mentally prepare yourself and you get through it. I do want to ask you, you mentioned holes. So the very first time I ever heard that leaflets had holes was in my case. And I made a big to-do because when you're a patient and you're not being the advocate, you are the worst patient. Don't they say that doctors make the worst patients too? That's what I thought I heard. So as an advocate, you make the worst patient because everything goes out of your mind. Why do people get holes in the leaflets?
So it's called fenestrations.
Okay.
And the reason for that is because the leaflets thinned out. So if you get a okay, like a kitchen gloves, all right, and then you start inflating, it dilates. And at the same time that it dilates, it also thins out. It thins out, and the fiber of it starts breaking down. So in the aortic leaflet, 2 parts, or if they have 2 or 3 parts, if the amount of stress on these leaflets, unilateral is or all direction over time, amount of stress on these leaflets and dilation of the aortic root, these leaflets they stretch, and when they stretch, the fabric of these leaflets, they become thin, and then it pops out, like it makes a fenestration holes in it. And that's the reason. Holes is, infection can cause holes in the leaflet. No, yes, but in patients with aortic aneurysm or dissections or connective tissue disorder, we see fenestrations a lot. That means these holes, because the fabric of this leaflet became very thin, now it basically pops out, and now we have an opening in these parts, in these leaflets, and that is the cause of regurgitation. Other cause of it is these 2 or 3 parts, they don't get to each other. They are stretched, and so they don't get to each other parts. So that's the other reason.
Okay. I want to take a couple quick questions before let me ask you a quick question before we do that. So if there's holes, I'm just wondering, does that put somebody possibly at risk for stroke? Because wouldn't blood have a second to just sit on that hole? No? Okay. I'm just,
No.
I have a very wild imagination. I told you that. So yeah.
No, it's these are very thin, these are very small fenestrations. Fenestrations are common, and especially in patients with connective tissue disorder, Marfan, Lloyd's, these. When we go there, to preserve their valve. We see fenestrations and holes in their leaflets. Some of them are participating in the in this coaptation, in this attachment between the. Some of them are not. If they are not participating in this attachment, we leave them alone. It's fine. Some of the whole, some of the these fenestrations could be here and not participating in this closure system.
Okay.
And in some, yes, fenestrations are participating, and so we have to either fix or replace this valve. So it depends on how many fenestrations. The technique that we use are different, but it will not increase the risk of a stroke for patients.
Okay. Okay. This is my wild imagination. All right. Let me not make it about me and take some questions from the community. So this person says, I have LQTS. Does that mean something to you, or was it I don't know if it's a typo. And so many meds I can't take. If surgery becomes necessary, this person's currently a watch and wait phase. How does that work with open heart surgery? I'm also at fall risk due to MS with severe falls resulting in broken bones and stitches and etc.
I think what they meant was long QTC.
Okay.
And it's a kind of EKG abnormality that we see time to time. That means between the systolic and diastolic phase of your heart, when the P happens, that means the heart been stimulated, and now the ventricle wants to gets the message and go to the systolic phase. Between that and the next phase, it's a little bit delay. It's not heart block, it's a long QTC.
Okay.
And it puts the patient at the risk of more severe arrhythmias, including ventricular tachycardia or ventricular fibrillation, with some other certain medications if they take. And that's why long QTC, we make sure that they specific medications we can't use for them. And we actually, after heart surgery, we check EKG, make sure it's not above 500, because amiodarone is a medication that can cause that. And so in those cases, we cut the amio or, give magnesium. So we check QTC, EKG, often, and actually it is important.
Okay.
And I'm sorry, the question
was, how does that going to work with open heart surgery if the person gets to the point where they need it?
It's not precluding patients from open heart surgery. It's something to be aware of, to not use medications. And at the same time, we make sure that, we have, sometimes if it's necessary, we have a defibrillator implanted for the patients by the EP team. So in case if they go to severe arrhythmias, including VTAC and VFib, it just gets censored and take the patient off out of that VTAC and VFib. So long QTC, it will not exclude the patients getting open heart surgery.
Okay. This individual is named Bonit. He's a type A and B dissection survivor. His aortic root was replaced in 21 with resuspension of his valve. Follow-up echoes have consistently shown mild regurgitation. 5 years out, he sometimes feels like he notices the regurgitation. What are the actual warning signs, symptoms, or test findings that would indicate the valve is worsening?
So short of breath is the most common symptoms that patients with regurgitation of valve they get. And on top of that, now that the heart gets distended, arrhythmia can add it to this. And chest pain is it's not very common with regurgitation of the aortic valve. And so most of it is short of breath. That's the most common symptoms they get, to catch their breath. And so that's the, and again, echocardiography, it can tell us if it's mild, it's mild. But if it gets to the moderate, and now we have some symptoms, it's time to add some modality, get MRI.
Get the MRI. Okay, good to know. A recent Danish study of over 16,000 people offers data bringing beta blockers into question for those with ascending aortic dilation. It also surveys other medical research that highlights the drawbacks of beta blockers in terms of arterial stiffness and central blood pressure. Do you think that beta blockers will be reconsidered at some point as the frontline treatment for thoracic aortic aneurysms?
That's a great question, and it's a lot of data we get almost every week about using beta blocker or staying away from beta blocker. For now, after coronary artery bypass operation, just a simple coronary artery bypass, we feel like, okay, having a beta blocker can help and improve the survival for these patients. And now in community, we felt like, okay, also for patients that they got aortic dissection and beta blocker can decrease the pulse pressure, at the same time control the blood pressure as well. But still, data that we get that it can affect the myocytes and the survival can not be changed using metoprolol or any other beta blocker. For now, I would say having a beta blocker, because it decreases the pulse pressure and blood pressure at the same time, my judgment is depends on how patients react to this beta blocker. Sometimes it really affects, it causes dizziness, it affects their daily activity. So and they, as soon as they get out and walk around, they feel like they feel dizzy.
Yeah.
So I get that out, because I really want patients to be active, get out and continue their exercise and daily activity. So I take that out. But I feel like, no, they are fine with the small dose of beta blocker. I add that to their medication regimen, mostly because it brings the heart rate down and pulse pressure down, and the blood pressure stays more stable in these patients. But if it has small symptoms, including dizziness and not feeling good as in their A game, I'll get that out. I don't put that. Yeah.
Okay. And people, there are so many different types of beta blockers. I can remember after my dissection starting off on labetalol, 300 milligrams 3 times a day, and I couldn't remember how to get home driving my car. I was so out of it. And then when I changed to Namivalol, like my whole world completely changed.
Yeah.
And I felt so much like what myself should be feeling like. So yeah. Okay, let's see. It's so funny. I have somebody here who has a consultation with you. I think in next week. That's what I'm reading here. Okay. This person's ascending aorta is measured at 5.2. It was an accidental finding, and the next door neighbor recommended you. So right now the person's a little shocked, little nervous, even though the cardiologist said that the person can still swim and golf. This person's too nervous, doesn't feel that safe swimming and golfing, and just kind of only walks maybe about an hour briskly a day, and wants to know, is it still okay to swim and golf? Is it okay to do the regular exercises that they're doing, at least until they see you next week?
No, so we heard about and the new guidelines, Karen. I think you have it, that exercise in patients with aortic aneurysm, right? It just came out, and we have a book. We actually give it to patients we tell the patients exercise is fine. Actually, we recommend that for patients with aortic aneurysm to do that. Guidelines didn't put a limitation. They didn't say, okay, don't lift up 180 pounds. They don't lift up 40, 50 pounds. They recommended don't push too hard that you feel like, okay, this is too much for you. Okay. That means if you've been lifting 10 pounds and it's easy for you, go for it. If you're lifting 20 pounds and you're easy for you, go for it. But if you're lifting 40 pounds and okay, I'm becoming red. My face is red now. And I feel that, like, we all do that, right? I mean, you are lifting something and okay, this is too much. You stop there. If you're doing push-up, you can do one, you don't become red, and okay, you can do it. Five, yes. But if you feel like, okay, the sixth one, somebody keeps telling, oh, you can do this, but you're stretching yourself and becoming red, you stop there.
Right.
Patients that they have aortic aneurysm, they can do swimming, they can do golfing, and as what is important is make sure that their blood pressure is controlled and their heart rate is controlled. And at the same time, if, okay, they have to run for something and they have to, they bring their heart rate and blood pressure to 220 or heart rate to 180, I would say I would stop that. That means you're pushing it for yourself too hard.
Okay.
If you go, you can go play pickleball. But if you are playing pickleball and now you decided to stay another hour because it's fun, and another hour, and on the third hour you feel like, okay, you are becoming red, and you stop there. So exercise is safe. We recommend that, but don't push it too hard for yourself. That, okay, this is my limit. You know what? I'm gonna just put it back. Go for swimming. But if you are swimming and then somebody told you, hey, catch your breath. I wanted to go this 50 feet without catching a breath. And you say, oh yeah, I'll do that all the time. But after 10 feet, you feel like under the water, you're stressing. No, come out. Okay, I'm stressing myself.
Okay, that makes sense. This next question is from someone 10 years out from emergency surgery, has a graft in the ascending into half of the arch. Has a stable root measurement around 4.4. It hasn't changed in 10 years. Had an echo last month and CTA was in October. Reached out to the cardiologist, haven't heard back yet. Been extremely sick with similar symptoms to the flu. One girl was actually hospitalized, told it was a virus. But bends over or squats to tie the shoes, having a lot of pressure in the chest, although it doesn't hurt. It's just heavy. And when this person goes to stand up, the heart kind of then goes into palpitations and the person starts to sweat profusely and feels a little bit out of it. Is this part of a virus, or can a virus affect your heart? Is this something that sounds I know some of these questions, it's hard to answer. Is this ER worthy? Haven't taken their blood pressure, doesn't have a home monitor, pulse has been running in the 80s, no fever, no chest pain, just heavy beats and some more rapid beats and pressure. So how do you tell if that's more heart related? And people go through this every day, especially in cold and flu season. You know, you get a cold and you don't know if what I'm feeling is, have I strained from coughing, I'm bending over, like what they don't know. And so there's a lot of ER trips because they're not told it's the cold, you're congested, or it isn't, it's something. The day you say it's just the cold, it's the day that ends up being something. So what would be a basic rule of thumb in dealing with any situation where it could very well be an external event that has nothing to do with, how do you determine this question?
Right. So you are absolutely right. This is common. And I can tell you my experience with this. And so to answer this, yes, viral infection can affect both heart and lung. It affects lung more often than heart, but it can cause weakness of the heart muscles temporarily and rarely permanently. That means it can cause myocarditis. That means inflammation of the heart muscles, and for short period of time, muscles are like sick, a little bit relaxed, and patients feel short of breath because the hearts are a little bit slower and less vigorous than it was. Or it could be pericardium, a layer that is, the heart is sitting inside this. You know, heart is sitting inside a layer, it's called pericardium. That also can get inflammation with any type of viral infection or and some other disease. So to differentiate between lung disease and heart disease, I can say it comes to really some of the tests that we get. X-ray can tell us, echocardiography can tell us, okay, is this a normal heart function now, or no, it's not normal. So it's very hard to tell if the reason for this is your viral pneumonia, or no, it's your heart that got some inflammation because of the virus. The only way to differentiate between this is with some blood tests and some X-ray and echocardiography that tell us. Why? Because the treatment for them, it's a little bit different. Although we use, okay, for lung pneumonia, sometimes we use antibiotic or corticosteroid, depends on how lung disease involvement, or some antiviral medications. For heart, if it's involved, we use heart medications, diuretic, some, take off some of the medications that patients were on, add some spironolactone after the load reduction, bring the patient's blood pressure down, so heart relax. So the medications and treatment for these two are different. So the only way is to either go to the ED and say, okay, if we are saying 80%, that is low. That is not, So I would go either to your primary care physician or to the ED with the O2 sat of 80%. That is low. To make sure we get an X-ray if the reason for this is lung inflammation, or echocardiography and some blood tests to see if the reason for this is the heart and any valvular disease, or no, heart inflammation.
Okay, makes sense. Here is a petite, youngish, 58-year-old female with low blood pressure, average 95/55, 53 resting heart rate, 113 pounds, doesn't smoke or drink, exercises every day, etc. No bicuspid or Marfan's or connective tissue disorder. Thought she was very healthy and active, and got hit with a 4.1 centimeter. So this is what she was told, ascending, and a 4.0 root diagnosis last year. She's now told she's low risk based on a 5 surgical threshold. So go live your life with no precautions, but lifting heavy over her head. But what is the threshold for someone like her with the short stature and etc.? She's also read, although this is difficult to find, that women should be operated on earlier or at smaller diameters, a full centimeter smaller than current guidelines, which are based on men. Does the fact that I don't possess the usual risk factors mean my aorta is more sick or at more high risk?
So this is a conversation that it's in the community all the time, and at which diameter we intervene, and especially when we hear that aortic dissection happens in patients that they had a less than 5 centimeter, that surgical threshold dissection happens. It makes people stressed. Like I was like, if the patient has a 4.6, 4.5, it's not there, and we know that aortic dissection can happen with less than a 5 centimeter aorta. So we look at every patient. Really, every patient's different to the other one. A lot of factors can come. We also stick with the guidelines as well. So these are coming together. I think earlier today I told you that if the patients want to become pregnant in a younger age, if they have a bicuspid aortic valve, the guidelines, the WHO guidelines says if it's 4.5, it's actually the threshold. And if they have a connective tissue disorder, 4.3, 4.4, 4.5, depends on type of connective tissue disorder. If 4 centimeter is on the lower side, and what we recommend is to blood pressure, heart rate control, surveillance, and continue exercise, and the monitoring. That means every year follow up with the cardiology and surgery team to really stay on this. And then I look at as well on the elongation of the aorta, because that's another factor. It's not in the guidelines, but I've seen aorta not only dilates, but it also elongates, especially when
okay.
patients age. And we looked at it, a lot of other centers have looked that when the aorta elongates more than 11 centimeter, that can put the patient at the risk of dissection. So again, when I look at a CT scan, I look at a lot of factors. Is this aorta not only dilated, but it's also elongated? Is it tortuous? Again, 4 centimeter is not the diameter that would cause all of this, but
Right.
if the patient comes with a 4.6 centimeter and is extremely elongated, and the patient is short and and had a family history of dissections, these are some of the factors that then you start thinking about how to approach this aneurysm and aorta, and then closely follow this. On your backside, me on my backside, always think about that patient. I like constantly make sure that I tell my team, hey, I need to see that patient again. Can you ask her to come and see me? I just need to make sure that her blood pressure is good, she's doing good. And I want to tell her or him, hey, I am here. All right. We are going through this journey together. It's not there yet to operate, but it's not like I'm going to forget about this. And then in 6 months, if I feel like, okay, now that aorta from 4.5, now it's 4.8, then it tells me, okay, this aorta is not behaving fine. Then I start talking about fixing this. 4 centimeter is on the lower side. We just need to monitor this, and you'll be fine. You know, if you were a dialysis patient, I would say make sure your blood pressure is good. Make sure you don't miss any of your dialysis session, because as soon as you miss it, then your blood pressure will rise up. But again, 4 centimeter, you just need close follow up. Make sure genetic testing, you don't have any of those, and then every year CT scan, chest, abdomen. That's our modality, CTA with contrast. If they cannot get the contrast, allergy or any reaction to that, MRI is another best option. Echocardiography on the guidelines is TEE. Please remember that. TEE is the transesophageal echocardiography, is the modality of choice for the assessment of the diameter. First one is CT scan with contrast. Second one is the MRI. Third one is TEE. TTE, transthoracic echo, is not even in the guidelines regarding the modality of assessment of the aortic diameter. I really want to emphasize on that. TTE is not even in the guidelines. It's because it's very obscure. It's not accurate. We don't know. TEE, transesophageal, gives us accurate images. So every year get that, and follow up with your cardiologist and cardiac surgeon. Again, every patient is different. And we go assess based on every patient.
Okay. I have 2 questions left. Do we have time?
Oh, yes, absolutely.
Okay. This person has ascending aortic aneurysm at 4.3. Aortic root is also 4.3. It was found in 2019, and it was 4.2. We have no mention of the aortic root being dilated, so I guess it's considered stable. The question is, I have the person has aneurysms. My brother also had an aneurysm. I also have another brother that we believe died from dissection at age 38. We were all told that he had a heart attack or something in around the heart, and it had failed and basically flooded his heart. I had genetic testing done and it came back negative for any genetic disease. Is it normal for 3 people to have aortic aneurysms in the same family and not have a genetic disorder?
Well, unfortunately, so far we only have identified limited number of genetic diseases. It could be other genetic disease that we haven't identified, right? I mean, Marfan-Loeys disease, MSK, and other all different type of genetic that we have so far identified. But there are some other genetic disease that so far haven't been identified, and it could be run through the family. So probably this is something familial in your family. but the genes haven't been recognized yet
Right.
because there's no test for that. So would you be at the risk of dissection? We can't answer it because we don't know what type of familial kind of genetic disease runs through that. But what is important is, okay, the lowest number of all of these genetic problems that we get so far, the guidelines for us, Lois-Dietz and Ehlers-Danlos, 4.3, 4.4 in the diameter, 4.5. The Marfan, 4.55 are the diameter. So I would say if you have a 4.2, 4.3, it's still not at the surgical diameter, and still requires, okay, every year surveillance. And if this aorta starts growing, gets to, okay, now I have a 4.5, all right, we keep monitoring this. And then if it gets to 4.8, 4.9, okay, it's time to address this, especially if you have a positive family history of dissection. That's an alarming sign for me. 4.3, I would not approach it. All right. And I'll look at the patient, make sure, okay, there's no syndromatic disease, but it's 4.3. I just ask this patient to come and see me in 6 months, get another CTA, make sure it's not expanding rapidly. Then I ask to come back, see me in a year. And then in a year, it's 4.5. All right. I'll see you back in 6 months, and then and if it's 4.5 stable, I'll keep eye on it. But if 4.5 in a year becomes 4.8, this is alarming for me. That means this in next year, it could come with a dissection, or it could come with a 5 or 5.1. So I start talking about surgery. Again, that's why I'm saying every patient is different. I don't stick, yes, I stick with the guidelines, but I also stick with other factors, history of malignant high blood pressure, short, less than 1.1, and then age is another factor. You are less than 50, 40-year-old, that's another different story than a 60 or 70-year-old. If a patient is 30-year-old, 40-year-old, has a long time ahead of her or him, versus a patient that is 70-year-old. All right. So a patient that is a 30-year-old and now has a 4.7 centimeter ascending, well, at some point, this aorta is going to get, like, he has many, many years ahead of her, versus a 70-year-old, yes, another 10, 15, 20 years ahead of her, versus a 30. So age is another factor for us.
Okay. Okay, the final question. Person was diagnosed with bicuspid aortic valve and stenosis and regurgitation, along with 4.3 ascending aneurysms, had 3 echoes, 1 CT, and a TEE. All just said bicuspid aortic valve. Went to another hospital for second opinion. Their echo and gated CT said tricuspid aortic valve with fused leaflets. The cardiologist says that hospital is reading the images wrong and that this person has congenital bicuspid aortic valve. How do I know who to believe? How does this happen? This actually could happen, this person read 20 to 30% of the time. So which would it? I would be saying find a third person, and the third person's a tiebreaker because that's how my brain works. But I didn't even know that you could have a tricuspid that's actually fused, so therefore technically wasn't born as a bicuspid. So what does that even mean? That's a whole new thing I'm learning.
So tricuspid aortic valve, that means they have 3 parts, right? And then if the 2 parts of the tricuspid becomes calcified and then attached to each other, it will look like a bicuspid.
Okay.
But let me say that calcification of the leaflet happens in who? In elderly patients, in those that they age, if they are 60 or 70 or 75 and they have calcium everywhere. And if they, on the echo, it shows, oh, okay, we have a bicuspid aortic valve with a fusion of the left and right. Used to be tricuspid. Yes, I can see that in a calcified, very calcified valve and vasculature system. very calcified. Bicuspid also becomes calcified and stays, calcification bicuspid. Tricuspid, if the leaflets become calcified, then it will look like a bicuspid. So again, I would say if you have an echo from 10 years ago that you had a bicuspid and now they did an echo and it's bicuspid. And if you had an echo, it was tricuspid, and now 10 years ago, and now you have an echo that shows, oh, you have a bicuspid, and because it's all calcified, and so that's probably the reason. I would say so your ascending aorta is 4.3, and you have either bicuspid or tricuspid. I and it's functioning, your valve is functioning as far as I understood. I would say for now it's just going to be surveillance. It's not something that you have to be worried about sick a lot. Why? Because the guidelines tell us, even for bicuspid, the guidelines tell us that ascending needs to be 5 centimeter. It's not 4.5. For tricuspid is 5, for bicuspid is 5. Yes, if we go and need to replace your valve, the guidelines tell us if aneurysm is 4.5, then we have to fix that and replace it. And that I can say during the operation, we really look at the aortic aorta tissue itself. If the aortic wall, when I'm cutting the aorta, when I'm cutting to replace that valve, if I feel like this aorta in a bicuspid or tricuspid is very thinned out, that means this aorta is not going to hold it for another 20 years. It will dilate. That aorta is thinned out. I will proceed with replacement. Already I've told the patient that, when I'm cutting that aorta to replace your valve, I have to do that. I'll look at the quality of your aortic wall tissue, and if it's extremely thinned out, I will replace it because I know this aorta is not going to hold it for 10 years. But if it's this quality is very good, it's holding. When I'm cutting it, it's very good quality tissue. I actually would not replace it. I get a lot of patients that they have this, and I tell the patient, you have a 4.2 or 4.3 aorta. I look at it. If the aortic tissue is good quality, I will not replace it. If I'm cutting and I feel like this aorta is not going to hold it, I will replace it. We don't want to add stuff into the chest during aortic valve replacement, and because it can increase the risk of infection, and overall, adding a graft, your heart function, it's dealing with artificial stuff versus a native aorta. Native aorta is always better to have than artificial graft in non-diseased aorta. So I'd rather not to replace it. When it's indicated, the data has shown it will not increase the risk of operative mortality, morbidity, complications. But when it's indicated, we'll do it. When it's not, then no. So again, 4.3 bicuspid or tricuspid, it will not, we just need a surveillance. You probably had a tricuspid, and if it's become now very calcified, fusion of the left, right commissures, I see this all the time, or fusion of the other two leaflets, we see this. And again, both could be right. I have to be honest. Timing could be a little bit different. TEE tells us a lot of data. That is this what is this what is going on? Is it fusion, or is it a real tricuspid or bicuspid? But again, it's for your case with 4.3, it will not change anything for now.
Right. Okay. So because we touched upon it real quick, yes, I did have moderate echo, but everybody that was listening to my valve said it sounded definitely severe. So this went on for a little bit, and then when we met, we did some additional testing, and we did decide it was time to make my replacement and my repair. And I did choose a cow valve, a bovine valve. And I will tell everybody out there who is facing a potential, look, it could be first, but second is very scary. I was not thrilled to hear that I was going to have to be cut open again, but I kind of remembered enough from the first surgery that I knew what I was getting myself into. There were some surprises along the way. I thought I had 2 chest tubes like the first time, but no, I had 4. I had to negotiate. I lost the negotiation. All 4 were coming out. But being able to have a doctor like yourself to talk through about this, understand the decisions that you're making, participate in some of these decision-making moments, and draw the diagrams, and just knowing that I could come to you at any time and ask the questions, between yourself and a really strong, solid nursing staff that listens, I would say, and I said it to you before, and I can't believe I'm saying it again, I'll have another one if I needed one, but hopefully you set me up where I don't need another one ever. But I would, because at the end of the day, I will say that you don't realize how poorly you might be experiencing life because you're so used to living in a what really is a less quality of life. You've adapted to not breathing as much. You become used to it. And then when you get a new valve and you're like, I walked up a flight of steps and I just kept on going. It sounds so minor, but for almost 10 years, I'd walk upstairs and collapse on a bed and need time to get myself together. I don't even think about it anymore. And I think this is amazing. This is what everybody else does. It feels so good. So I would highly recommend to people. I know it's scary. You know, what I've realized is all the books that I could write, all of the speeches I can give, every situation is different. My third, if I have one, will probably be different than the first 2. And so you can prepare yourself as much as you can. You can create a plan with your physician, right? We can have these conversations, talk through. I think that you would prefer to have conversations with your patients and understand their experiences, and is it on the verge of being maybe a more traumatic past experience? So let's communicate a little bit about this. What do you need to make you be the most compliant participatory participant, basically, and what do I need from you to make your wishes come true? We often say that's not a struggle, a power struggle. It's really a power balance, and that can only lead to a 2-way street for success. So I had it. I'm here, jazz hands. I'm living. I'm doing really well now, and so much better than I was October 28th. So I thank you for that, as always. I always will. But I want to thank you because I know this is not a clinic day. I do not believe, if I've got my days correct, and I think I know your schedule. Thank you so much for taking time
No,
out
of course,
today.
Karen.
Yeah, to really answer these questions for people. And I always learn something new from these. So thank you for that as well. And I look forward to having you back on if we can in September for Aortic Disease Awareness Month. We can talk about a whole different topic, and I think it would be very exciting.
Of course, thank you so much, Karen. You brought up a very important point that this is a 2-way street. This is between patient and the surgeon. It's like a family that I think I told you. This is a book chapter. We are opening it together, and we will close it. Move on to the next chapter. We do it together, and we did it. So
I love
you are
that.
awesome. Great to see you. I'll
It's
see you
great to
soon.
see you too. Hey, everybody, don't forget to click like, click subscribe so you're notified when these new videos pop up, and share this because there's people in your life that you might not even be aware. Look, dissections are rare, but aortic disease is much more common than you think. So share this on your pages and let other people become really well educated as you are today. So thank you again, and we'll see you soon. All right,
All
take
right.
care.
Take care.